Yeah, if I get going, I'll note out to everybody. I can't get the hospital. We can't get a radiation oncologist in the hospital, which is the weirdest thing.
Which hospital?
In Northside, down in St. Pete. They've been trying for a couple of years. I just can't get her.
That's because they won't negotiate. This is Faraz, my friend, his group has a monopoly.
Oh, is it? Okay.
And they just, it's I'm sure that they won't pay.
I'll call you. All right, so go ahead. You're up. We see it.
Okay.
We can see the screen. It's kind of a funny view. Hold on. Side by side. Speaker maybe? There we go. That's a little more satisfying. Oh, did I do that? Yeah, that's okay. Go ahead.
You can see the first slide.
Yeah.
Okay. Okay. So thank you, Dr. Cohen, for this case. We have a 30-year-old male who reports he's always needed glasses. He goes to annual eye exams. However, the last time he was there was a concern about his eyes. He does report a positive family history of eye problems, for which all of his family members use glasses, but he is unsure if they see normally. In terms of his past medical history, he does have anxiety and depression. His medications include meloxicam, lorazepam, and methocarbamol. Vision is 20/40 in the right eye, corrected, and his vision in the left eye is 20/20 -2. His IOP by tone of pen is 9 in the right and 12 in the left. Oops. So here we have the first photo.
So it's a color fundus photo of the right eye. The media looks clear. The nerve looks pink, sharp, flat. Then I would say overall, I don't know if the image is just really bright, like it's the camera, but the retina itself looks a little bit more pale than expected.
It's a 30-year-old. Madeline, there's some red flashing thing. Are you seeing that on the top of your screen?
Oh, no.
Okay.
Maybe if I move this.
Oh, hold on. Let me look at what it says. We might.
I think you have a chat. You have someone in the chat, maybe?
No, hold on.
That's been there. Something about the recording.
All right. Go ahead. Sorry, we'll just keep going. like a cat. I just keep looking at it. Yeah.
To the top right.
It doesn't bother me.
No.
Is it okay? I'm not sure what it is.
We just switched. We'll see if it does it. Go ahead.
Okay, so then attention's drawn centrally. There's this large, irregularly shaped, let's say like yellowish lesion with surrounding area of a more pale color. And then the remainder of the picture looks normal.
You mentioned the retina look pale. It actually doesn't. I suspect this is a darkly pigmented individual.
Okay.
The reflexes there, the reflexes of youth. Enjoy them while you have them.
Yeah, this is a 30-year-old patient. Okay. And next picture.
Color fundus photo of the left eye. And you also see your nerve looks pink, sharp, flat. Then again, attention's drawn centrally. There's a round area. Looks like the retinal discoloration. Centrally, there's some area, like a darker area of yellow pigment, and then maybe some more reddish brownish pigment.
Okay. Then we have the fundus autofluorescence in the right eye.
On autofluorescence in the right eye, centrally, there's an area of hyper autofluorescence, and essentially area of hypo autofluorescence.
Okay, and then here's the left eye.
The left
There's...
eye, also an autofluorescence, few areas of hyper autofluorescence, kind of ring fashion, correlating to what we saw in the color fundus photo, and then centrally also area of maybe hypo autofluorescence. So OCT, think of the right eye.
Yeah,
Centrally, there's this large deposit that's disrupting the foveal contour. Can't tell really if it's sub-RPE. I don't appreciate the RPE layer distinctly, but it looks like it might be sub-RPE.
I think it's pre, because you can't see the sub-RPE because the lesion over it
Okay.
is attenuating the signal. And it's probably a little ratty under there, but that's not just the basal membrane. That's not the Brooks membrane. It's
Okay.
thick enough to be RPE, so it's pre. It's
Pre-RPE.
pre,
Okay.
by my interpretation. I mean, it's not, we don't have it, you know, it's not under a microscope. And then you get the shadowing, see?
Other than that,
Okay. And then same OCT on the left eye.
in the left eye, again, so foveal contour is disrupted. Area of the. So it's like somewhere.
That's your RP layer there. See it? You're perfect. Who's doing the arrow?
That's me.
Yeah, that's the RPE layer.
Okay.
So it's pre-RPE. It's
Some retinal fluid.
yeah.
Mhm.
There's like some
Okay.
speckle there. That's okay. Keep going.
Okay,
Keep
so
going
this, yeah, sorry, go ahead.
What do you think of the outer segments there hanging down?
I think they're definitely sick.
Yeah, they're ratty. It looks ratty, irregular. And there's some of them are on the bottom there, aren't they? They fell off. So probably some outer segments. I'm guessing. I mean, again,
And is the chloride thick?
It looks thick.
It does look thick.
yeah. All right.
Okay, so summary, basically we have this 30-year-old male. He has a history of a refractive error for which he follows an optometrist, anxiety and depression, and also reports a strong family history of poor vision in his family that's unspecified. I put the images here if you want to just kind of summarize the findings in both eyes.
A young male, positive family history of vision loss in his both eyes. He has these central macular lesions that have a yellowish hue, and then on this autofluorescence, there's hyper autofluorescence appreciated in both. And then on OCT, it revealed that there's some fluid or subretinal fluid in the left eye, and then a deposit or an exudate in the line. So.
Okay, yeah, do you have a differential in mind before I go over it?
Differential. So I would say best disease is on there, just on the view. There's that North Carolina district. Yeah. And then there's the areolar retinal.
How about something we saw earlier today?
And then the pattern dystrophy. Yeah.
Okay. Yeah, so I had best disease on there, age-related macular degeneration, especially in the left eye where you have that subretinal fluid. You could think about CSR or serous macular detachment. Also the adult fovea macular vitelliform dystrophy, which we went over earlier. And I also threw familial dominant drusen on there, although I know that it kind of has a different fundus appearance. So in this case, it is best disease. It's just classic egg yolk appearance of the fundus. So it is a genetic disease associated with an autosomal dominant mutation in the BEST1 or VMD2 gene, which is on chromosome 11, and it encodes this bestrophin protein. I found this in ophtho questions. I don't know if this is helpful for people. We're just remembering that it's on chromosome 11 to just think of the two L's as being ones. It has variable penetrance and expressivity. The bestrophin gene is a transmembrane calcium-dependent chloride channel that's found in the RPE cell. So it helps with regulation of anion flow into and out of the RPE cells. So the pathophysiology, it's not completely understood, but this is kind of the best mechanism that I could find for explaining how the disease occurs. So there is reduced activity of this bestrophin protein, which is an anion channel across the RPE. So this leads to fluid accumulation and dysregulation of the homeostasis of the cells and between the RPE and the photoreceptors. So that reduces the ability of the RPE cells to phagocytose the outer segments of the photoreceptors. And that can cause accumulation of toxic fluorophores, most notably the lipofuscin. And that gives it kind of that yellowy appearance. This also causes toxic injury to the photoreceptors and RPE, which can present in the later stages of the disease. There was also on iWiki a discussion about abnormal cholesterol homeostasis causing a chronic inflammatory stimulus in the RPE cells, which reduces the adhesive forces between the RPE and photoreceptors, further damaging their ability to phagocytose the outer segments and leading to more accumulation of the lipofuscin. They also have found that the RPE cells that have BEST1 mutations have retraction of the apical microvilli. So presentation, it is the second most common macular dystrophy after Stargardt's disease. They usually present with good vision until middle age. And at that time, oftentimes the visual acuity will sharply decline, which can be due to formation of a choroidal neovascularization, scarring, or geographic atrophy. 30% of patients will have bilateral lesions on presentation, like the patient that we had in this case. So just to review the stages, stage 1 is called the pre-vitelliform stage, and that is basically when if you were to get an EOG at this stage, they would have a subnormal EOG, but there aren't any clinical symptoms and the fundus appears normal at this stage. This is usually in infancy and childhood. Stage 2 generally develops in childhood or young teens. And this is where they develop that classic egg yolk or vitelliform lesion. And it's usually between half a disc diameter to 2 disc diameters in the RPE. They can have bilateral lesions, as we discussed. It can also be unilateral, or they can have asymmetric lesions. They can also present with extramacular or multiple lesions in the fundus. And then stage 2 is called the pseudohypopion stage. And that's essentially when this lipofuscin begins to partly regress and kind of sinks to the bottom and gives it this appearance of a hypopion. Usually this is in the teen years. And then stage 4 is the vitelloruptive stage. And this is classically kind of called the scrambled egg because of the granular sort of appearance of the lesion at this point. This is just when the lesion starts to break apart and also the vision begins to sharply decline starting at this stage. Stage 5, so this is the atrophic stage where the pigment starts to disappear, that lipofuscin starts to disappear, and they can have atrophy of the RPE in the outer retina. This kind of patchy geographic atrophy appearance can also make it difficult to distinguish from AMD. And then stage 6, this is when they develop a choroidal neovascular membrane formation, and this occurs in about 20% of patients with Best disease. They have a sharp decline in vision. Often their vision is worse than 2200 when they get to this stage. So the diagnosis is clinical. There's obviously genetic testing that can be supportive. And then EOG is kind of the gold standard for testing this because it's characteristically always abnormal. They have a severe loss of the light response. and a decline in the light peak to dark trough. I'll go over this because I wasn't too familiar on how EOG worked. So I have a slide next that goes over this form of testing. But characteristically, the Arden ratio is less than 1.5, which is a ratio of the light peak to dark trough. And they'll have a normal ERG. They can also have the hypofluorescent lesions when it's in the vitelliform stage. It becomes mixed and then hyperfluorescent in the atrophic phase. For the fundus autofluorescence, they'll have hyperautofluorescence in the vitelliform phase, which is due to the lipofuscin. It then becomes mixed, and then in the atrophic phase, it's hypoautofluorescent. So the EOG, it's a measure between the resting potential between the cornea and the Bruch's membrane, and it's done by using electrodes that are placed on the medial lateral canthi of each eye, and then the grounding electrode is on the forehead. It basically is measuring the function of the outer retina and the RPE, which is why it's used in Best disease, because this is where the primary dysfunction is. The mechanism is when the light goes in, it causes the calcium-dependent activation of the bestrophin protein on the endoplasmic reticulum of the RPE cells. And that causes release of chloride from the RPE cells, which results in depolarization. And so during the light peak, there is a attenuation of this response in Best disease because the bestrophin gene is dysfunctional. So that chloride channel isn't as responsive. So they have a reduced light peak, which causes a reduced light peak to dark ratio of less than 1.5, which is also called the Arden ratio. And this graph here is kind of showing a kind of normal response to the dark trough and the light peak. It's usually at least 1.8, this light peak to dark trough ratio. And then in Best disease, they have an attenuated response or an attenuated light peak, which results in a reduction in the Arden ratio. So in the end stages of this disease, they can develop RPE, sub-RPE fibrosis, geographic atrophy. 20% of them, as I said, develop a choroidal neovascular membrane. They can also have subretinal hemorrhages with minor trauma and also develop macular holes. There isn't any medical or surgical treatment for the disease itself, but the choroidal neovascularization can be treated with anti-VEGF agents. And since it is genetic, that you can evaluate family members for similar symptoms as well. And that's it. Here are my references.
That was very well done. Thank you. That was excellent. Yeah. The something I think I learned is you mentioned the minor trauma. One thing you'll get when you get pediatric patients is whether they want a sports restriction, like can my kid play football? And I don't like restricting patients. I think doctors over restrict patients. However, I think Best is one of the diseases you're supposed to restrict. I think pseudoxanthoma elasticum too.
Pseudoxanthoma you're supposed to restrict.
You're supposed to restrict. And I think Best is another one because I had a kid that got a hemorrhage and later I was like, ah, shoot. And the thing is, I've seen people, I have a retired family practice doctor with Best disease who sees pretty well. So you can have good vision. And then the last thing is the subretinal fluid's challenging because most patients with Best disease have the subretinal fluid, and do they have a neovascular membrane or not can be really challenging to figure out. I think they might get overtreated. I don't know. But that was very good. Thank you.